welcome. We'll give folks a few more moments to join, and then just at a couple of minutes past the hour, we will get started. Thank you all so much for being here. Hi, everyone. Thanks for being here. Just another note that we'll wait one more minute before we get started, but excited to see you all. Thank you again. All right, I see we'll have more folks trickling in, of course, getting started after this holiday weekend, never easy, and there's a lot going on. But let's jump in and get started. Hello, everyone. Thank you so much for joining us, and welcome. Thank you for taking this hour out of your afternoon to join us for this important conversation. I'm Chelsea Cipriano. I'm the Managing Director of the Common Health Coalition, which is a coalition of over 300 organizations in 45 states, all working together to improve the health system through better partnership between healthcare and public health. Today, we're here to talk about a really important topic on all of our minds. That's respiratory season vaccines and how to navigate the system ahead, the season ahead, my apologies, particularly for you health leaders out there. What clarity around communications, operations, how we talk about this and how we do it are critical for ensuring access for our patients and for our communities more so than ever. We have an expert panel of folks here to help us navigate these uncertain waters ahead, and we're just going to jump right in. Without further ado, we know there's confusion. We know you've got questions, so I won't waste any more time. Let's intro the folks who we have on with us today and get started. So first, Dr. Dave Choksi, chair of the Common Health Coalition and former New York City Health Commissioner, bringing healthcare and public health together has been, one of his career achievements and goals, and we're glad to have him here with us today. Dr. Charlene Wong, pediatrician and national health policy leader, one of our close Common Health Coalition partners and advisors. Most recently, she was at the CDC and the North Carolina Department of Health. Dr. Caitlin Jetelina, epidemiologist and founder of Your Local Epidemiologist, making science accessible to millions every day. Erin O'Malley, executive director of the Coalition for Trust in Health and Science, with her own decades of experience in policy advocacy and partnership across the health spectrum. And Amanda Kwong, director of the Public Health Communications Collaborative, which is really here to bring us all together and equip the field with clear, consistent messaging across topics. So quite the panel of folks, if I do say so myself. We are excited to get started. I will do a quick overview of our agenda today. We'll do a quick situational update. We'll clear up the air around recommendations and what's going on with them for the 3 respiratory virus vaccines, COVID-19, RSV, and flu. We'll talk about how to communicate all of this amidst the confusion, and we'll open the floor for questions. We'll leave lots of time for questions, so don't worry about that. We got some pre-submitted. We encourage you to ask them in the chat as we go, and we will get to just as many as we can. With that, I think I have a few housekeeping issues to run through, and then we can turn this over to Dave. Number 1, Live closed captioning is being provided by AI Media. If you'd like to use closed captions, hover over the More button on the bottom of your Zoom screen, and that will enable the captions. ASL interpretation is also being provided today by Keystone Interpreting Solutions with Kyle and Judy as our interpreters today. Thanks, Kyle and Judy. If you'd like to use ASL interpretation, hover your cursor over the interpretation button on the bottom of your Zoom screen. And finally, today's webinar is being recorded. It'll be emailed out later this week and available on our websites. So if you know someone who's missing this or you have to hop off early, no worries, we got you. Okay, I'm done. Dave, I'm going to pass it over to you and kick us off. We'll get the slides going and kick us off with what we know and what's going on. Thank you.
Thank you so much for that welcome. I think I'm just adding my welcome here, actually, and I'm going to pass it to Dr. Charlene Wong. And then I will take just 10 minutes to walk through some of the situational update. A lot has changed over the last few days, and then we will pass it over to Caitlin to say a little bit more about communication after that. So over to you, Charlene.
Thanks so much, Dave. Thank you, Chelsea. So, of course, the number one question we're getting this season, as frankly we do every season, is who is recommended to get flu, COVID, and RSV vaccine. So if we could please bring up the slides. We have created, as we did last year at CDC, a single figure, a single table to help folks understand currently who are the 2025, 2026 respiratory vaccines recommended for. Just to orient you to this table, you can see down the left side, we broke this down by populations. Which infants and kids should get this? What about in pregnancy? What about adults of different ages? And then the columns you can see across the top are the 3 different vaccines. So let's start with the first column, which is the blue column, flu vaccine. Great news, everyone. This is pretty stable and straightforward this season as it has been in past seasons. In a nutshell, everyone 6 months and older should be getting this year's 25-26 updated flu vaccine. This has been recommended by the Advisory Committee on Immunization Practices, or ACIP, that's part of the CDC. This has also been, and that recommendation has been aligned to by the clinical medical associations. For example, as a pediatrician, I'm a member of the American Academy of Pediatrics, and the American Academy of Pediatrics has also said all children 6 months and older should be getting this year's updated flu vaccine. The same thing for the American College of Obstetricians and Gynecologists have said everyone who is pregnant should get this updated flu vaccine this season. And then you can see the same thing for adults. I will note, as in past seasons, for our older adults who are at higher risk of getting really sick, that means hospitalization and even worse with flu, RSV, and COVID, you can see the flu vaccine, as in past seasons, there are some special, even more protective vaccines for older adults if those are available to older adults in their community. All right, let's move to the middle column. This is the RSV immunization. Again, great. Oh, sorry, let me back up. Flu. The time to get the flu vaccine is right now. I am sure many of you all have seen, for example, signs maybe in your local pharmacy saying, come get your flu vaccine. If you are working in a clinician office, this is the time to send out those reminders to your patients, come and get your flu vaccine that's waiting for you. All right, now we're going to move on to the middle column, which is RSV immunization. This is also good to go, relatively stable recommendations from last season. In fact, we even have more options and expanded eligibility for protection against RSV. So for our infants and children, and for those of you who don't know, RSV is the #1 reason that babies in our country get hospitalized every fall and winter. I and Dave and I have both taken care of babies who get RSV. It is a horrible thing to see. And so this has been really life-changing and has actually cut the number of kids being hospitalized, babies being hospitalized, in half in our country. So we want to make sure that babies this year continue to be protected. So as with last year, all babies under 8 months old, as well as children who are 8 to 19 months old with risk factors, should be getting this vaccine, this immunization. Now, this is a timed vaccine, just like the rest of these. So this is typically October to March. There are 2 options to protect these babies. Either the baby themselves can get the vaccine, Or a mom who is pregnant can get the vaccine when she's between 32 and 36 weeks pregnant. And so you can see there on the chart that you can see either the infant can get it or the mom can get it. And you can see the time frames. I will note we actually have an additional option for infants and children this year. Last year, we only had nirsevimab available. This year, we have clesrovimab available as well. And yes, I have practiced saying those words. For adults, you can see certainly those who are pregnant. And then for our older adults, same as last year, all adults 75 and older should be getting an RSV immunization. You only need one in your lifetime at this point. So if you've had one before, you're covered at this time. This year, we actually even saw expanded eligibility. So last year, it was only adults down to age 60. This year, it's adults down to age 50 with risk factors also are recommended to get a single dose. And I just want to note, similar to COVID vaccine, which I'm about to talk about, the indications for RSV for these risk factors are also very, very common conditions. So anyone with diabetes, anyone with chronic heart or chronic lung problems, anyone who has severe obesity, these are very common conditions. So many, many adults who are 50 and older are going to qualify and are recommended to get that RSV immunization. All right, let's turn to the last column on this table, which is the gray column. There have been more changes, and there's still some unknowns for COVID-19 vaccine this year. One thing that maybe you all saw in the news last week is that the FDA did make some updates to the way that these vaccines have been approved and licensed for this year. So they're now approved for adults 65 and older and people, kids and adults aged 6 months to 64 years old who have at least one condition that increases their risk for getting really sick. Now, I want to just say again out loud, it is even a broader list of conditions that is a high risk condition, as it's called, that would make someone eligible for the way that these vaccines have been licensed by the FDA. We estimate that probably at least 3 in 4 adults in this country have something like diabetes. Their weight qualifies them as overweight or obese. They have any heart or lung condition. They have cancer. They're pregnant. They have a disability. They are physically inactive. They live with someone who is at high risk of getting very sick from COVID. So again, this risk list condition is actually quite broad. In addition to what the FDA has licensed and approved the vaccines for, we also have, similar to for the other vaccines I just said, groups that are making evidence-based recommendations for who should get the vaccines this season. So for COVID-19 vaccine, the American Academy of Pediatrics has recommended it for all young children ages 6 months to 23 months, as well as children 2 to 17 years old, if either they have one of those very long list of risk factors I mentioned, or if their parent desires their child to be vaccinated. For pregnancy, the American College of Obstetricians and Gynecologists have recommended that all pregnant women, get a COVID-19 vaccine, the updated one for this season, at any point in their pregnancy. And then for adults, both those 18 to 50 and those older adults, right now, the recommendation is for all adults also to get the 2025-2026 updated COVID-19 vaccine. And this is based on the recommendations of medical societies from last year, who have said those recommendations remain in place while continued work goes on with recommendations for this season from them, as well as the ACIP group I mentioned earlier. All right, with that, Dave, I'll turn it back over to you.
Thank you so much, Charlene. That was a terrific overview, as usual. I see so many comments in the chat and the Q&A about the slide, so I just want to emphasize what has been stated, which is that we will be sharing this afterwards for everyone who has registered. So stay tuned for that. And huge thanks to Charlene, Chelsea, Caitlin, and many others who have put that together amidst the dynamic circumstances that Charlene has described. I wanted to just take a moment before I pass it to Caitlin to pan out for a minute to talk a little bit about what this all means and why it matters. And I know I'm speaking to a group of folks who already know why it matters. It's why you're here to learn more and to make sure that you're up to speed on these most recent developments. The way that we talk about our role in the Common Health Coalition and with our partners is to make sure people can access vaccines in a way that is affordable and where they're simply easy to get. We also want to make sure that people understand why recommendations might look complicated at first glance, but then to parse through that complexity in a way that makes sense. The mantra that we often say is that clarity is the antidote to confusion. And we hope that we can enlist you as part of the team to spread that message, as far as we can. I know we have a number of clinicians and public health professionals who are on the call. For all of you, we hope it means being ready to explain the current guidance clearly and consistently. In my own clinical practice, I've already started fielding questions from my patients. And so, for example, just as Charlene modeled, I've started to refine the conversations that I have with the patients that I'm serving to start with flu and RSV, since those are simpler recommendations and very important with respect to the protection that they afford, before I get into some of the complexity and the questions around COVID-19 vaccines. For communicators, we think that this means helping people understand both what is known, but then, as Caitlin will say a bit more about, to prepare audiences for uncertainty. People will ask, why do these recommendations keep changing? Am I still supposed to get vaccinated? I'm hearing different things from different quarters. These are reasonable questions, and we want to meet people where they are in their understanding, bring evidence-based information, but importantly, to start with a listening ear. When it comes to conveying that evidence-based information, the overall message we hope that you'll carry forward is that we have safe and effective immunizations that are available for flu, RSV, and COVID-19 this season, and each plays a role in reducing the risk of severe illness across different populations. The last thing that I just want to touch on is why this matters. Those of you who are clinicians have all, as I have and as Charlene alluded to, we've all taken care of a patient gasping for breath who will be forever etched in our memory, in part because we know that their suffering was preventable. Thinking about this from the public health perspective, increasing vaccination rates against these viruses, even by just a few percentage points, translates into thousands of hospitalizations averted. And look, I want to be honest, this is always a tall task for us ahead of any respiratory virus season, but that's especially true during this one, given the change in guidance that we've seen and some of the controversy surrounding COVID-19 vaccines in particular. So it's a tall task, but especially ahead of this one. But I hope you'll agree that this is an extraordinarily worthy goal for us to dedicate ourselves to, because so much of that suffering that we've talked about is avoidable. Okay, with that, I have the pleasure of introducing Caitlin Jetelina, your local epidemiologist, to whom I'll hand it over to talk a little bit more about how we actually communicate this information without adding confusion. Thanks so much, Caitlin.
Yeah, hello everyone, and thanks for having me, Dave. I want to start with this, that communication is as important to public health as the vaccines themselves. We are in a moment where the science is very strong, but the confusion is widespread. And with very limited resources in public health and really no coordinated national campaign funded by the federal government to set the record straight, the responsibility is going to fall on all of us, right? As clinicians, as public health leaders, as trusted messengers, as whoever you may be that need to fill the gap. I wasn't able to put together slides because of the craziness of this past couple weeks, but there's 5 things that at least I'm leaning on in this moment that I wanted to bring to your guys' attention that may be helpful in your communications when talking about fall respiratory vaccines. One is all communications should be very clear up front. And this is what I love that Charlene did in the beginning, is that flu and RSV are basically business as usual. They are ready. You can and you should go get them. The guidance is straightforward and everyone basically agrees. I think the worst thing that can happen in this moment is that all of the COVID-19 confusion bleeds into other vaccines, which could lead to inaction, and then we lose ground in all of them. Now, COVID-19 vaccine is the moving piece, and I think that we have to be very careful and very precise in the communication, as this is really what matters most right now, right? Who is recommending what? One big lesson I learned during the pandemic is don't underestimate the public. They can and deserve nuance and complexity if it is communicated clearly. And so really keep, as in my head, the RSV and flu as well as COVID a bit separately in the communications and very clear. The second is something that as a scientist makes me very uncomfortable, but there is immense power of storytelling. People do not just need more facts and charts. They need teachers, they need storytellers, and they need narrators. Storytelling makes public health messages resonate. Stories help connect people, right, with complex issues on a very personal level. This is what Maha, for example, is incredible at storytelling, at charisma, at humanizing health challenges. People make health decisions based on what matters most in their lives, right? Protecting loved ones, keeping their kids in schools, avoiding missed work. And this is where the conversation really needs to begin with vaccines. So lean into as much storytelling as you can, right? So for example, you could say, imagine a grandmother who wants to stay healthy enough to be at her granddaughter's wedding, or a mom getting vaccinated during pregnancy so her newborn has antibodies. Storytelling anchors the science, the data, the facts in daily life, and we can start from very much shared values. So far more people are likely to engage and to act and to get vaccinated this fall. The other thing to really keep in mind is that words matter. They shape what is considered, what is acceptable to them, and what is even inevitable to them. So recognize and resist strategies that you see kind of going around on social media to preserve vaccine integrity. Being human means that when you're communicating, realize that there's another human on the other side. And this is especially important that when people are hesitant or believe in even conspiracy theories, because when we respond without empathy or in a very disconnected way with some of the actual words we use, people will double down, rejecting the data and the evidence even more, because basically their views are linked to their identity and the tribes they're a part of, and we need to set new foundations of trust. So, for example, what does this mean? You will never see the word misinformation in any of my communications. This is a trigger word. That word can make people feel judged, and it makes people feel labeled about something they're hearing or they understand. Also, don't use words like absurd or insane because those also do not resonate with people. So other words I use is questions, concerns, rumors, falsehoods, different information people are hearing, because this framing opens up the door to conversation instead of closing it. Similarly, words like safe and effective, they're true, but they're not always the most meaningful to people. What's meaningful is saying that, again, this helps keep your kid in school, or this lowers your chances of family gatherings getting disrupted by illness. So use words that resonate. This is connecting our work in vaccines, in evidence-based research to values and emotions. And those words will tie directly back to the values people hold and the actions they ultimately take. Okay, the next thing I always think about is opening up a two-way street. Something as nurses, as scientists, as public health leaders, as health systems, we know our stuff, but we do not know everything. So listen instead of hear. Learn together with your audience, with your community, to address the needs on the ground. And this really means opening up for a bi-directional relationship with the community. Ultimately, this means that the audience or your community or your patients is not merely a target, but an active participant in this process. So ask questions, go look for questions. If you're posting on social media, go read the comments. Try to understand where people's heads are at. People want to feel heard, and we need to recognize that humans have an emotional relationship to information. And we need to hear what their priorities are, what their questions are, and where the confusion may be laying. And then my fifth tip is to be honest. Truly be honest about what vaccines can and cannot do. Don't oversell, right? Saying this vaccine will stop you from getting sick sets up people for disappointment. So instead say, this makes illness much less dangerous. Vaccines are very powerful, but they are not perfect. And they won't stop every infection, and people still may get positive. They still may have mild symptoms, but they do consistently protect against the worst outcomes. And we need to communicate this balance, right? Realistic expectations without underselling the benefits. So 5 things on my forefront with the communication. 1, be clear with flu and RSV. For COVID, bring people along for the ride. 2, there's really huge power in storytelling. 3, words matter. 4, open up this two-way street with your audience, with your target population. And then 5, be honest. We are facing a lot of confusion, very limited resources in public health, and there's going to be a vacuum of national campaigns around vaccines. It's daunting, but I also think that this is an opportunity for us, right? Local messengers, clinicians, pastors, nurses at schools, community leaders to step up and provide clarity. Because at the end of the day, of course, vaccines all save our lives, but communication that is clear, that is empathetic, that is values-based is what ensures that everyone can have their life saved by vaccines. So that is all I have. Not sure who should get it next. Chelsea, are you up or Dave?
Thanks, Caitlin. Okay, next, I think we are passing to Erin for a few words on, oops, I'm so sorry, I have a joke, on trust.
Great. Thank you so much. It's a pleasure to be here today on behalf of the Coalition for Trust in Health and Science. We were formed about 3 years ago, coming out of COVID, in a moment that has some vibes and feelings like the one we're in now. A lot of uncertainty, the polarization, politicization of the moment, the fact that people aren't really sure who to go to, who to trust, or what is what. And as we were organizing today's webinar, the organizers and I felt that we needed to pause before we move into Q&A to really underscore just how pivotal the issue of trust, and in particular trustworthiness, is in this moment. Caitlin outlined 5 incredible steps on how to communicate effectively through this moment. And I really want to underscore her point that vaccines are critical, but so is effective communication. When we look at any poll, we know that you, our audience today, public health professionals and officials, nurses, doctors, pharmacists, those on the front lines, you are our trusted voice, you are our trusted messenger. And so in combination with the tools that we've talked about today, with an understanding of the evolving landscape, especially around vaccine policy, as well as just what exactly will happen this respiratory virus season, we've put together several pages full of resources. And at this point, we'll turn over to the slides. We have a great QR code and link out to the page with our resources. but wanted to ensure that you, our audience, had the tools at your disposal to lead with trust in your communication, in your engagements with individuals. I think we're still struggling to pull the slides up at this point. But when you do get to the resource page, you'll find that we have toolkits for you, regardless of where you sit across the health and science ecosystem. We have them for payers, for states, providers. We have regulatory and legal briefs to help explain the complexity of this moment. We have some great toolkits and other resources, one-pagers for providers. I know our coalition has been really focused on providing tools to professionals like you out in the field to engage in trust and trustworthy ways. I'll now turn to Amanda, who will give us a brief overview of the work that the PHCC is doing, in particular to ensure that the public health community is aligned on messaging.
Sure. Thank you so much. Hi, everyone. I've been working on the back end of things, but Amanda Kwong, Director of the Public Health Communications Collaborative. We've been keeping our ears and our hearts on the ground, hearing what you guys all need. Certainly clear, concise, evidence-based messaging is a key one around respiratory season and vaccines. And so as a follow-up, I'm going to send through a couple of different resources. We have landing pages. We've been really trying to keep them updated based on guidance from ACOG and AAP, but we'll send over in afterwards. But I think they go well in tandem with the resources that Erin has outlined here from Common Health Coalition and Coalition for Trust in Health and Science.
Thank you, Amanda. I think we are now ready to move into the Q&A portion of our conversation. I know we have a robust chat and Q&A box, and Chelsea, I'll turn it back to you to help moderate this part of the webinar.
Thank you so much, Erin. Thank you, Amanda. Thank you, Caitlin. And thanks, Dave. We have had a very busy chat in addition to the questions that we got in advance. So we'll keep, maybe we can pull the slides down and just kind of look at each other for a bit. And Amanda, thanks so much for dropping the link to those resources in the chat. Those can all be found at commonhealthcoalition.org. When you're at the top of the page, resources, tag vaccine resources, and it'll take you to this landing page where we just shared all this information. So, first and foremost, I think one of the questions that we've seen again and again in the chat is about insurance coverage and folks being concerned or confused about what will be covered by insurance, particularly for those who are offering vaccines to patients or deciding for their system what to do. So Dave, I'm going to kick it over to you for this question to start us off, and then I'm happy to chime in as well.
Thanks so much, Chelsea. I'm happy to. This gives me a chance actually to model the types of communication that Dr. Jetelina was talking about. So I'll say two things at the start. The first is that with respect to the flu and RSV immunizations, coverage is straightforward. It's what it has been in the past because there is a universal influenza vaccine recommendation for those 6 months and older. And then for RSV immunizations, it's the same as it has been last year, with the additions, meaning the expanded eligibility that Dr. Charlene Wong went over. So that's with respect to flu and RSV. And importantly, we shouldn't skip over that when we are talking about the COVID-19 vaccines. The second point is to acknowledge that there is some uncertainty around insurance coverage for the COVID-19 vaccines. But let me articulate what I think we can hang our hats on. First, the health insurance associations, particularly AHIP and ACHP, the Alliance for Community Health Plans, have signaled earlier this summer a commitment to continue covering vaccines in a way that ensures their affordability. And in fact, I'm just going to read their very short statement. Maintaining robust immunization coverage continues to be a top priority for protecting both individual and community health. We are committed to ongoing coverage of vaccines to ensure access and affordability for this respiratory virus season. we encourage all Americans to talk to their healthcare provider about vaccines. That's important at a high level, but there are still some questions about what this means for individual health plans. At that level, there may need to be conversations, about what specifically is covered for a given patient or a given member. There's one other point that I do want to speak to before turning it over to you, Chelsea, which is it may not be commonly known that insurance coverage decisions are not tied to the FDA label, but rather to CDC recommendations through the Advisory Committee on Immunization Practices, or ACIP. So that is to say, the FDA label change that happened last week does not have a direct effect on how or if health plans cover vaccines. Most minimum coverage requirements are tied to ACIP recommendations, and for the COVID-19 vaccines for this season, those recommendations remain outstanding, as was discussed earlier. We believe they will be discussed at the September ACIP meeting, and so there may be some additional clarity after that meeting. But even then, ACIP recommendations should be considered the floor and not the ceiling with respect to what payer coverage looks like. Let me just composite all of that to say there is reason for optimism that COVID-19 vaccines will remain covered without cost sharing, but there are some nuances around what will happen around ACIP, and one should always advise, getting in touch with individual plans if there are specific questions for a given person. Chelsea, please add whatever you would.
Absolutely. Thanks, Dave. I think, and I see another question in the chat that this will probably be answered by, but we have a number of resources on our page that include legal and regulatory analyses, so that the coverage matrix that Dave just went over very quickly about where the authority for coverage lives, that is on our website. We'll also drop it in the chat to help folks better understand that for coverage, ACIP, not the FDA label, really is that floor for payers, and they can always cover more than what ACIP recommends. Two, folks may have seen the coverage from Reuters this weekend that Aetna came out, or CVS Health, Aetna, said that for plans that it operates and funds, the company will continue to provide coverage for COVID-19 vaccines with no cost sharing. And so those types of statements from payers, I think, are what we are looking for to see if there are additional payers coming forward to say that. And as Dave said, if folks have questions, directing them or yourselves to speak with your own insurers to ask what they will be covering and for whom, and based on whose recommendations, is absolutely an action that we can all take for our own coverage. So thank you. That's that I think covers the insurance questions that I saw coming up in the chat. There was a question about whether if the ACIP meeting is postponed indefinitely and there's no ACIP recommendation, that is another scenario that we cover in our toolkits. We have toolkits for payers, providers, and states. And so we get into kind of the what ifs there, because we want to make sure we're thinking through all of the potential what if scenarios in those resources as well. So hopefully you find a lot of answers and help from those resources, but we're always looking to update them. Next, let's see. The other real set of questions that we've been receiving, off the bat is about where we stand with shared clinical decision making, and if that is still, if that's still the lay of the land, and if any of that has changed. So, Dave, I'm happy to pass to you on that one first, and then I can follow up. And I think Charlene may have hopped off, but if she's still on, can have her jump in there as well.
Yeah, no, I see Charlene is back, so actually I think she would be best positioned to start. I'll pass it to you.
Amazing.
And I'm sorry, Chelsea, my audio was not on yet. Can you say the question one more time?
Not a problem. It was about shared clinical decision making.
Yeah.
Just kind of where do we stand?
So currently on the CDC immunization schedule for children, the recommendation for COVID-19 vaccine is listed as shared clinical decision making. As I mentioned, and as you saw on the table, the American Academy of Pediatrics made their recommendation, which is now publicly available, which does state for 6 months to 23 months, all younger children, as well as older children who have a risk factor or whose parents desire it. The reality is, as a pediatrician, we are talking with our patients all the time around what vaccines are recommended, and having conversations, answering the questions, giving the nuance like Caitlin already recommended today. And so I think right now there are still some questions, and I will say I see a lot of questions about vaccine coverage for vaccines, and I think there are still some outstanding questions, for example, around our Medicaid insured children and who is able to get those, and when COVID vaccine will be available to, for example, Medicaid insured children under the Vaccines for Children program. But the recommendation, shared clinical decision making, what the American Academy of Pediatrics recommended, essentially say any parent who wants to get their child vaccinated should be able to get their child vaccinated.
Great. Thank you. Zooming out a bit, this is one question we received ahead of time, several questions about who can give the vaccine and thus where can I get it. I think a lot of the news over the weekend and late last week about CVS, Walgreens, and other pharmacies with their access to COVID vaccines for folks with pre-existing conditions has created some confusion. So Dave and then Caitlin, why don't you take this one?
Yeah, sure. So I'll start again by saying, so as not to skip over flu and RSV immunizations, that's straightforward. And in the same way, you were able to get your flu shot or RSV immunization, by providers, including physicians, but also others. That remains true for this season. So essentially no change in terms of administration, just the changes to eligibility criteria as Charlene went through earlier. That's for flu and RSV. For COVID-19 vaccines, there are some changes to talk through, and I'll start here, and I'm sure Caitlin will have other thoughts to add. And it's really segmented into whether there are patients who meet the on-label indications for the vaccine versus patients who do not meet the on-label indications. So people who meet the new label indications, it's the same as what you did for flu and RSV. Essentially, through a pharmacist, physician, nurse, or other healthcare provider, that access should continue. For patients who do not meet the on-label indications, it may make it harder for those people to receive COVID-19 vaccines. For example, a healthy 30-year-old who doesn't meet the high-risk criteria, and we should spend a minute talking about the high-risk criteria and where to find those as well. But for the sake of this example, a healthy 30-year-old who doesn't meet those high-risk conditions will either need to find a provider to prescribe and administer the vaccine off-label, which is still permissible, but may come with some liability considerations, meaning that fewer providers will be willing to administer it. And then importantly, pharmacists in many states would not be able to administer it to a patient who does not meet one of the label indications. Just to reiterate that last point, 90% of COVID-19 vaccines were administered by pharmacists last season. And for patients who do not meet the on-label indications, it will be more difficult to access COVID-19 vaccines from a pharmacist this season. Let me turn it to Caitlin.
Dave, fantastic. I totally agree with all you said. I want to add one level of nuance that we're starting to see peppered throughout the news is there's going to be great state level variability around who can get a vaccine and where. Right now, I think it was New York Times or Washington Post reported that 16 states are not able to go get COVID vaccines at CVS or at Walgreens because those those standing orders for pharmacists are directly connected to ACIP. Now, other states may have other standing orders for their pharmacists that don't rely on ACIP. Other states may start putting together emergency orders for a standing order for pharmacists. And I'm sure there's other situations. Some may be trying to change their laws. So over the weekend, we saw New Mexico is going to start exploring what that could look like. So while the national picture of COVID is confusing enough, at least in my brain, it's going to definitely get state specific as well. And I just want us to be very cognizant that how pharmacists can give vaccines or other administrators can give vaccines very much relies on state authorities and laws as well. Chelsea, anything I'm missing?
No, I will share in the chat the resource from NASPA, the National Alliance of State Pharmacy Associations. They have a great map that really shows pharmacist vaccination authority across the country. When you look at that map, you'll understand, for those who aren't deep in the weeds, just how 50 state strategy this really is, because each state really does have their own authority about who can administer vaccines, and particularly COVID-19 vaccines. So we'll put that link in the chat as well. Thanks, Caitlin. Thanks, Dave. Let's talk about high-risk conditions. I think there's a lot of confusion around high-risk conditions. And I do think getting some clarity around what that looks like, how it's defined, is helpful for people to understand who can access the vaccines right now. So Charlene, why don't you kick us off on that, and then Caitlin chime in as needed.
Great. So the high risk condition list, and I believe Chelsea or someone, Caitlin, maybe just put the link into the chat. I just want to reiterate again, the number of things on this list and the number of people who qualify with a high risk condition is at least 3 out of 4 adults and maybe almost as many children. So again, certainly all older adults, as we already mentioned, but for those 6 months to 64-year-olds, as we were talking about, on or off-label use of the vaccine. It's anyone with everything from any heart issue, any lung issue, any liver issue, any kidney issue, basically any organ in your body. If you have an issue with any of those, you would qualify. But even more important, if you have, for example, if you are physically inactive, that is on the list of qualifying conditions. If you are a smoker or a former smoker, that is on the list of conditions. So, the list of conditions here on the high risk list currently are very, very broad. And so while there is a lot of questions and confusion around, what's this label narrowing done, particularly for adults for COVID-19 vaccine, this is still the vast majority. When I say 3 out of 4, that's a conservative estimate, likely. 3 out of 4 adults likely see something on this list. The other thing I will say, and this is evolving, right? As healthcare providers are working through, okay, how do I check, right? How do I check if somebody has one of these conditions or not? I would say we're hearing again, there are people taking different approaches, but in general, some of the larger, say, vaccinators are using forms or questions that are just, do you have any of these, right? Check if you have any of these that would make you eligible to get a COVID-19 vaccine. And again, these are things that we should watch over time, but at this point, we are glad to see that this list of high-risk conditions has remained very broad.
Perfect. Thanks, Charlene. And I just want to note that I forgot in my comment previously about pharmacists that the national pharmacy associations are also all working together to identify what can be done and the nuances of the state authority and limitations at the state level. So apologies for that oversight. Next, let's move on to community groups and engagement with community, because I know many of them are probably listening right now. How do we ensure that community groups feel engaged in this work by the institutions and organizations working on vaccine access? Erin, let me pass to you on that one.
Sure. Thank you. That is a critical question. I think of this in essentially three steps. So one is organizing, casting a really wide net, ensuring that when we think of who to bring in, who to tap into in the community, we are not only talking to those of us in health science and public health, but individuals in housing, in business, etc. And in doing that organizing work, being sure that we're all on the same page is critical. As we've discussed throughout our webinar today, yes, we're moving through uncharted territory, very complex territory, but having an infrastructure sing from the same song sheet is critical. I think the second step is listening. Once we have aligned ourselves and we are singing from the same song sheet, how do we ensure that the messages are being absorbed by and understood by the people that we're communicating with and to the patients and consumers that we're engaging with? And then finally, rinse and repeat. How is this a learning cycle? If anything that we take away from today is that the landscape is still evolving, which is why coming back to all of the resources and resource pages that we outlined earlier are critical, in that we've all committed to update this content as we learn more, as the landscape evolves, but being sure that it's a cycle, and that all of the community organization efforts that we build are continuously being energized with and infused with the latest information as we know it at that moment.
Great. Thank you. And thank you. I know there's also answers being given in the chat to your questions. Thank you, Dr. Gentilina, for answering those live. We've gotten some questions about non-pharmacists, but NP and public health nurses. I'll take that one. I think the answer really is state dependent. Ultimately, when it comes to this off-label administration of vaccine, the authority and autonomy of those providers is going to be dependent on state licensure, so including those advanced practice practitioners. So sorry to have a better answer there, but we do have resources about the PrEP Act and liability coverage. Dave alluded to the difference between physicians who can prescribe off-label and do so quite frequently, but as we get into nurses, NPs, PAs, and other advanced practice practitioners and pharmacists, of course, that really does depend on state authority. We've gotten a couple of questions. I think we need to back up a little bit just about have the COVID vaccine strains been updated for this year, and what does that mean in terms of what is being administered right now? So maybe just a little bit of the basics of what's happening in terms of what does FDA label approval actually mean? Dave, you got into this a bit, but do you want to build out a little bit more on what that means for the vaccines going into arms now?
Certainly, I'm happy to, and I'm sure Charlene and Caitlin can jump in as well. Well, look, let's just start with how the process, normally goes forth. Each respiratory virus season, so around August, the FDA approves seasonal COVID-19 vaccines based on the agency's determination that a vaccine's benefits outweigh its known and potential risks for the intended population. The FDA-approved label includes the indications for use, including the indicated disease and population. And so what happened with respect to the FDA label last week was that the 25-26 COVID-19 vaccines, which are updated based on the variants of COVID-19 that have been circulating more recently, those vaccines were approved with the indications, that we've already talked about with respect to adults 65 plus and people over the age of 6 months with conditions that put them at high risk for severe COVID-19. One thing that may be worth talking about a little bit is the specifics around each of the manufacturers' different vaccines, because there are some nuances with respect to the age thresholds for Moderna, Pfizer, and Novavax. And so maybe I'll pass the ball to someone for that. Charlene, do you want to take that one?
Yeah, just to keep it simple, there is not a preferred COVID-19 vaccine across those three, so Pfizer, Moderna, and Novavax. There are different ages that these vaccines are approved for. So Moderna is approved for 6 months and older. So if you have an infant or a child under 5, you're looking for a Moderna vaccine. Pfizer's vaccine is approved for individuals 5 years and older, and then the Novavax is 12 years and older.
Great, thank you. And there, we've gotten a couple of questions about the pregnancy, if there's a pregnancy restriction for any of these vaccines, and confusion about pregnancy in general. So Charlene, you want to just continue your
Yeah.
answer on that one?
Flu vaccine, go get yourself any of the flu vaccines that are available on the market. I do want to note for the maternal RSV vaccine, and we are hearing more moms and seeing in the data, more moms are getting vaccinated during pregnancy because they want to protect their baby when they're born. It is important that right now it's only the Pfizer, it's called a Brisvo RSV vaccine is the one that is approved for use in pregnant women. And then for COVID-19 vaccine, again, any of the vaccines for COVID-19 that are available are recommended at any point in pregnancy per the American College of Obstetricians and Gynecologists.
Wonderful. Thank you so much. We only have just a couple of minutes left. So, I want to touch base really quickly on communicating out about these recommendations. Caitlin, I'm going to pitch this last question to you. What should local health departments, other communicating public health organizations, health sector partners, hospitals, doctors themselves, what's the one thing right now they should be doing about proactively communicating out about these science-based recommendations from the medical societies?
Well, I'm biased, but I think you need to print out that table that we put together to let people know where we're at with all of these three things. People also want to know what to do, like what is their action? And I think that there's a lot that people can be doing if they want to go get a vaccine and they can't find it. One is call their pediatrician, call their family doctor and ask if they have a COVID-19 vaccine or any vaccines, and if they don't, where to go. I think too, there was another question in here about, is it a pain to call your insurance company? I think that calling your insurance, giving people the action to call their insurance company to see if their vaccine is going to be covered is very important for a lot of Americans. These vaccines can be expensive, more like $200. And that's a decision between putting food on your table versus getting a vaccine for your family. I think that is a very actionable item to do as well. One, provide the information we have today. You can do a table. Wiley is going to be putting out a table as well tomorrow, like whatever is most helpful to communicate, as well as give people actions and listen to concerns from a place of empathy on whatever side of the spectrum people are at. I guess that's where my head is at. And then I try to answer as many questions as quickly as possible through the Q&A. So I hope that we were able to be responsive in real time too.
You did great. Thank you, Caitlin. Dave, I'm going to pass to you to close out. Final thoughts.
Oh, thank you so much. Well, I just wanted to strike a note on the big picture here at the end, because look, those of us who are on a webinar like this one, it's our job to know the nuances. And so we spend a lot of time talking about the details because those are critically important. But it's equally important that we inhabit the mind of the people that we're serving with respect to the big picture. And the big picture is more straightforward. Flu and RSV immunizations remain broadly accessible. And given what we've talked about with respect to the list of high-risk conditions for COVID-19 vaccines, they should also remain relatively accessible to the people who will most benefit from COVID-19 vaccines. So across all three, it's our job to ensure that the benefit of that protection extends as far as we possibly can. So amidst all of the confusion and controversy, which is legitimate and which we have to parse through, I want to make sure we all don't lose sight of that big picture as well. And I'm so grateful to be able to partner with all of the folks who are on this town hall and to all of you who tuned in to try to accomplish this worthy mission together. Thank you.
Thanks, everyone. We'll see you soon, and you know where to find us and the information if you need it. Have a great one.